Today I will be talking about sickle cell disease. Sickle cell disease refers to a group of red cell disorders resulting from inheritance of the sickle beta globin gene. So here we have a section of the beta globin chain. Glutamic acid is at position 6, and this is what the normal beta globin chain is. The codon for glutamic acid is GAG. Just think back to biochemistry and amino acids and nucleic acids. Okay. In sickle cell disease, valine replaces glutamic acid at position 6. Now, the underlying mutation that makes this happen occurs in chromosome 14, where there's a substitution of thymine for adenine in the 6th codon. And so instead of having GAG, which we said is the codon for glutamic acid, what you have is GTG, which codes for valine. And this is what results in sickle cell disease. It's called sickle cell disease because the cells actually look like a sickle, as opposed to the normal red cell. Okay. The common genotypes are SS, SC, S beta thalassemia. SS, which is also known as sickle cell anemia, is the most severe, and AS is the sickle cell trait. You may be wondering, how does one little substitution lead to this problem? Let's look at the normal hemoglobin. Normal hemoglobin has two parts, the heme part and the globin part. The globin part consists of 2 alpha type and 2 beta type chains. In sickle cell disease, what is affected is the beta globin chains. Okay. Now, the normal hemoglobin, if we look at the cross section of a normal red cell, the normal hemoglobin looks like this. Is neatly arranged. There's no disorganization, as you can see here. Now, in sickle cell disease, what happens is the hemoglobin S molecules are structurally and functionally abnormal. One important thing to remember is that glutamic acid is hydrophilic and valine is hydrophobic. Now, because this hemoglobin S molecule is abnormal, under the oxygenated conditions, hemoglobin S undergoes a major decrease in solubility, an increase in viscosity, and there's polymer formation. So this polymerized hemoglobin forms these long rigid tubes, which causes the hemoglobin to develop its sickle shape. Here we see those tubes of the polymerized hemoglobin. Now, at first, the sickling is reversible. So when it is deoxygenated, the cell sickles, and then when oxygen returns, it goes back to normal shape. However, after repeated episodes of sickling and in quote unsickling, what happens is that there's membrane damage and the sickling ultimately becomes irreversible. So even with reoxygenation, the cells remain their sickle shape. These sickled red cells may block major blood vessels, small blood vessels rather, and this could lead to ischemia and infarction. The damaged cells are also continually removed by the spleen, and this is why it's classified as a type of hemolytic anemia. Certain conditions are known to promote sickling, and these conditions include infections, dehydration, extremes of temperature, most cases is mostly cold, hypoxia, so think of high altitudes and extremely strenuous activity like exercise. Patients with sickle cell disease may present with symptoms that suggest underlying hemolysis. So they are pale and they have jaundice, which is yellowing of the skin, the mucous membranes, and the sclera. And this occurs due to the release of bilirubin from this excessive breakdown of red cells. They may also present with a crisis, an example of which is the vaso-occlusive crisis, and this is the most frequent crisis. This vaso-occlusive crisis occurs because the sickle cells block blood vessels within the body. It can occur in the bone, also known as bone pain crisis, and this typically involves the hip and the shoulder. The first presentation usually is dactylitis, also known as hand and foot syndrome, and the child has painful swollen digits. It may also affect the spleen, and usually at around 8 years, there's autosplenectomy due to the repeated infarction of the spleen. It could also occur in the brain, leading to a stroke. Another type of crisis they might have is the aplastic crisis, and this occurs from infection with a parvovirus or due to a folate deficiency. Both situations will cause a decrease in the production of red cells. Now remember we said that patients with sickle cell disease already have a short lifespan of red cells, and so any hindrance to the production of the red cells would severely exacerbate the already existing anemia. They present with worsening symptoms of anemia, and the complete blood count would show low hemoglobin as well as a low reticulocyte count. In some cases, patients with sickle cell disease may present with sequestration crisis. This simply means there's pooling of blood within organs, and this pooling worsens anemia. Acute chest syndrome is the most feared complication of sequestration crisis, and it may be precipitated by infection, a pulmonary embolism, pulmonary infarction, and it typically presents with chest pain as well as difficulty breathing. Splenic sequestration could also happen, and this would cause splenic enlargements. Earlier, we stated that the abnormal red cells are removed by the spleen, and in some cases, the spleen may become overactive, and this could lead to a hemolytic crisis. Other features that patients with sickle cell disease might have include frontal bossing, thin, long limbs, and this is because the medullary centers are overreacting and they're trying to churn out red cells at a faster rate. They could also have leg ulcers due to stasis and ischemia, and usually they present with poor growth and development. Chronic complications of sickle cell include sickle cell retinopathy, sickle cell nephropathy, hepatopathy, avascular necrosis of the femur head, and osteomyelitis. Osteomyelitis is more common in patients with sickle cell and it's usually due to Salmonella or Staph aureus. So what investigations do you want to do in a patient with sickle cell disease? First off is your complete blood count. Remember when we talked about anemia, we said complete blood count is very important to do. And this would show low hemoglobin and high reticulocyte count. Once again, think back to the last video. Because red cell production is unaffected, reticulocyte count is high because the bone marrow is trying to compensate for the low hemoglobin by churning out red cells quickly. Another test that can be done is a blood film. The blood film may show the sickle cells that have been irreversibly sickled, and in patients with no spleen or hyposplenism where there's reduced spleen function, you could see Howell Jolly bodies. These bodies are remnants of the nuclei that are supposed to be removed by the spleen. Now, tests that can determine the presence of the sickle hemoglobin, that's hemoglobin S, include the solubility test and the sickling test. The sickling test is done by subjecting a blood sample to deoxygenated conditions. So a blood sample is placed on a slide, the edges are sealed, and then it's covered with a cover slip, and this creates a deoxygenated environment, and this causes the cells to sickle, and then it's examined under the slide. In solubility tests, a blood sample is mixed with a reagent that lyses the red cells and reduces the free hemoglobin that has been released. Hemoglobin S is insoluble and that makes the solution turbid, as we can see in this picture. When the test tubes are placed in front of the test lines, you would notice that you are unable to clearly see the lines behind the test tube that has the presence of hemoglobin S. The solubility test, the sickling test, are unable to differentiate a sample from a patient with sickle cell disease from a sample from a patient who just has the sickle cell trait, which we earlier said is AS, because all they can tell you is there's a presence of hemoglobin S. In order to properly determine whether or not this test sample is from a patient with just sickle cell trait or a patient with sickle cell disease, hemoglobin electrophoresis or high performance liquid chromatography is required, and this is what is done to make a diagnosis of the red cell genotype. With this test, you can see the composition of hemoglobin in the blood. This is an example of a high performance liquid chromatography result. As you can see, there's an S peak without an A peak, so this shows the presence of sickle cell anemia. Management of a patient with sickle cell disease starts with patient education. It is important for the patient to understand the condition and what management involves. It is also important to avoid those common triggers that we mentioned earlier. Folate supplementation is another important part of management. Because the red cell turnover rate is high, unlike iron, folate cannot be recycled from the destroyed cell. Thus, it is important to supplement folic acid to prevent further exacerbation of the anemic state. Infection prophylaxis is another important principle of management. Patients with sickle cell need to be on malaria prophylaxis, oral penicillin, and receive the pneumococcal vaccine. This is because they have a high susceptibility to pneumococcal infections, and these infections can be very serious in patients with sickle cell disease. Treatment of a crisis involves hydration, rest, and analgesia. It's important to treat an infection if it is indicated. Exchange blood transfusion is indicated if the patient has a cerebrovascular accident or acute chest syndrome. And if the patient has severe anemia with symptoms, a blood transfusion is also indicated. Hydroxyurea is a drug that can be given to patients with sickle cell disease. It induces the production of hemoglobin F, which reduces the polymerization of hemoglobin S and leads to a reduction in the number of crises. It is indicated in patients who have frequent crises, require recurrent blood transfusions, or who have had a previous cerebrovascular accident or acute chest syndrome. A stem cell transplant is the only known cure. In summary, sickle cell disease is a group of red cell disorders resulting from the presence of an abnormal form of hemoglobin, hemoglobin S. The presence of this abnormal hemoglobin causes the red cell to sickle when deoxygenated, and these sickle cells have a very short lifespan. Patients with sickle cell disease must be well educated on the disease and its management. Management involves folate supplementation, infection prophylaxis, and crisis treatment. Stem cell transplant is the only cure. Thank you for watching this video. If you enjoyed this video, feel free to like and subscribe to my channel.